Understanding prostate cancer. There are a number of important things to know about this disease before talking about the best form of treatment, such as the stage and the grade and the histology. One of the most interesting aspects is the anatomy of the prostate and how close it is to the bladder and the rectum. It's worth noting that cancer tends to arise along the edges or the periphery of the prostate, and this can make it difficult to treat surgically to be sure the surgeon gets around the edges of the cancer. There's a wrapper called the capsule around the gland, and there's always a risk that the cancer can invade through the wrapper or the capsule, and it's quite common for this to be involved on a pathology report. There are also nerves close to the prostate along the back and the side. If the surgeon cuts these nerves, it can affect impotency, and many procedures now are called nerve sparing to try to avoid that. There are also lymph nodes that surround the prostate, and cancers that have a higher Gleason score may spread to these lymph nodes and need to be accounted for when the patient receives treatment, either surgery or radiation. Here's an autopsy picture of a prostate and how close it is to the bladder and the rectum. You can see an MRI view of the same anatomy next to it and see how well these images match up. Here's a picture of what's called cross-sectional anatomy. This would be a slice right through the prostate, and you can see how close the prostate sits between the bladder, which is drawn in yellow, and the rectum, which is nearby. These are other anatomy diagrams showing prostate and bladder anatomy right through the area of the bladder. There's a structure called the seminal vesicles that's right behind the bladder. This is another cross-sectional view right through the prostate. And again, you can see how close the prostate sits between the bladder and the rectum. These images are used quite frequently to target radiation. This is another view of a cadaver sliced right through the bladder. Again, just showing the anatomy, how close these structures are together. Another anatomy view right through the prostate. And again, the position of the prostate between the bladder and the rectum. Here's a typical CT scan right through the prostate, and it gives you an idea of the average size of the prostate, which is circled in red in this picture. Here would be a CT showing a much smaller prostate. After hormone therapy, the prostate can shrink down in size. This would be a CT showing a very large prostate. The normal prostate is about 35 cc's. This picture is about 60 cc's. Here's an even larger CT showing a very large prostate pushing into the bladder and pushing down against the rectum. Here's a CT of a very large prostate. This patient had a PSA over 1500, and the prostate is now pushing and actually invading into the bladder. This is unusual but can occur in advanced cases. This would be an MRI showing how nice the anatomy can be visualized with an MRI scan. Both CTs and MRIs can be used to analyze and evaluate the gland and help aim radiation beams. This would be a side view of the prostate using an MRI, and you can see the bladder being pushed into by the prostate, and you can see the pubic bone in front and the rectum behind. This is a MRI that actually shows a nodule in the prostate. Most cancers are not visible on MRI or CT, and the cancer is usually diffusely through the gland and doesn't form a lump. The stages of prostate basically are 1 through 4, and they reflect how far the tumor has advanced in the prostate and whether it's spread to any structures, such as the lymph nodes or the bone or seminal vesicles. The most common stage we see now is early stage, where patients have an elevated PSA, and in most of these patients the biopsy was done because of the PSA and nothing can be felt in the gland. This is called stage 1 or T1C, when the cancer cells are too small to be felt, and is the most common stage. Again, T1C would be prostate cancer too small to feel, biopsied because of an elevated PSA. If the physician can feel a lump or a mass in the prostate, as in this diagram, then it's called T2. This is less common than it used to be, but is a little more advanced than T1. Another picture of T2, big enough to feel. This would be T3, where the cancer has spread even further into the structure called the seminal vesicle. This is a structure just above the prostate on the back of the bladder and can sometimes be felt. If the cancer has spread to the lymph nodes, which you would see on a CAT scan, or into the bone, which you would see on a bone scan, then that would put the patient into a much higher stage, so-called stage 4. The stages, again, can be broken down into the T category. T stands for tumor size, and this is a reflection of how far the cancer has grown locally, if it's confined to the prostate or has formed a lump or has invaded any of the structures nearby. The N category has to do with whether the cancer is spread to any lymph nodes, and the M category has to do with whether the cancer has spread even further, and the most likely risk would be to the bone. Putting the T and the N and M together gets the staging classification for prostate, and the system now includes the Gleason score and the PSA. So all this information is necessary to classify what stage the patient is in. The prognosis or survival, no surprise, is related to the stage. The more advanced the stage, the more likely it's spread, and the lower the overall long-term cure rate. Survival is related to the PSA. The higher the PSA, the more serious. With surgical patients, once the PSA has gotten greater than 10, the lower curve here, the cure rate is much lower. With radiation as well, the higher the PSA, the higher the likelihood of a relapse. As long as the PSA is less than 10, the risk of a relapse after radiation would be quite small. The typical patient who's treated with radiation, the PSA will slowly decline over a period of months, and ideally should get less than 1. It's worth noting that the low point on the PSA may not occur for 18 or 24 months, so this is a very slow, gradual process. Another typical PSA curve after radiation, again pointing out it takes many months for the PSA to stabilize and get down below 1. Sometimes the PSA bounces up about 18 to 24 months after treatment. This is harmless. And another example of a so-called PSA bounce, as long as it turns back down, there's no consequence to this, and it doesn't imply a relapse. And another case including seeds, the PSA can get very close to 0 when you combine external plus seeds. The next important thing is the cancer grade. The more mutated the cells have become, the more dangerous. These cancers are called adenocarcinoma, which means cancer arising from a glandular organ. And the closer the cancer cells look to normal, the less serious. The more mutated or high grade, the more serious. And the cure rates decline, again based on how mutated the cells have become. A poorly differentiated cancer under the microscope has a much worse outlook or prognosis. In the last 20 years, the pathologists have used the Gleason scoring system, which ranks the cancer cells from normal, almost normal looking, score of greater 1, to very mutated, which is a score of 5. The cancer is scored twice and the sum added up, so between 2 to as high as 10. The Gleason system is fairly accurate and reliable. Again, the lowest possible score would be a Gleason score of 2, and the worst or most dangerous would be a Gleason score of 10, calculated as 5 plus 5. The cure rates with surgery decline significantly in patients with a higher Gleason score. Anything with a Gleason score 8, 9, or 10 is considered high risk or much more serious. Similar to surgery, the cure rates with radiation decline if the Gleason score is higher. Patients with radiation often benefit if hormones are combined with the radiation, particularly in high Gleason score patients. The cure rate with radiation or seeds as well declines based on the Gleason. But with seeds or high-dose radiation, the Gleason score may not be that significant. So overall, prostate cancer classification now combines all three things: the stage, the Gleason, and the PSA. The best group or low risk has a Gleason score of 6, PSA under 10. Intermediate would be Gleason 7, PSA 10 to 20, and the high risk group